Okay, well, good afternoon and welcome to the AI Med webinar. My name's Freddie White. I'm the CEO of AI Med. Very excited to be presenting this webinar to you guys today. We've got Kabrina and Chris that are going to be joining us. I'm going to be taking over from here. And yeah, we're really looking forward to the session. Over to you guys. Thank you very much.
Thank you. Thank you to AI Med too for hosting this. I'm Kabrina McGinn. I'm the marketing manager for our CDS solutions portfolio here at Beckman Coulter. And our product today that we're featuring is TriageGO, which is the AI tool that can recommend an acuity level at triage. Yale New Haven Health was actually the second health system to adopt TriageGO. We have with us today Chris Chmura, who has been an ED nurse with Yale for over 17 years and currently serves as their manager of clinical projects. And he's going to talk to you today about implementing TriageGO across 3 of their sites and the benefit and the experience that they had with the tool. Thanks, Chris.
Awesome. Thanks, Kabrina. Thanks, Freddie. And thanks, AI Med, for hosting us today. And thanks to all of you that have called in or logged in today's meeting, regardless of where you are. I'm here on the East Coast in Connecticut. So again, I'm Chris Chmura. I am a nurse and I work for Yale New Haven Hospital here in Connecticut in the US. And today we're going to be talking about how emergency nurses can harness the power of the health record data to improve decision-making tools, specifically at triage. So let's get my stuff working here. All right, so from objectives today, I'm going to try to run through this here. We have the describe the operational journey of implementing new methodology at triage for nurses, discuss kind of how that standardization and redistribution of patients across acuity levels that present to emergency departments. I'm going to review some data and some patient outcomes for here at Yale and then also at Johns Hopkins. And really, for me, I wanted this is all about empowering nurses to make the best decision possible with the information that they have at hand, and really improving that nurse to provider communication. And kind of, I'll talk a little bit about a shared mental model as it relates to triage. So a couple disclosures. So this presentation, topics and implications for practice in nursing and emergency medicine discussed represents my opinions as and my experiences with the tool. And I am an emergency nurse, it's a disclosure, and an educator by training. So I'd like to say, like most emergency nurses, we're kind of the jack of all trades, master of none. You have to know a little bit about everything. And well, that can make you a little dangerous. It's like me doing a project at home, whether it's with electricity or plumbing, could just be a little dangerous. But I do have a passion for project management, IT, data analytics, resuscitation science, and some pre-hospital works, kind of my passions. But just some disclosures about me. So some of you might have different training and abilities or know some things a little bit more than me, but so I appreciate any questions or comments as we go through this presentation. So first, let's start and talk about the emergency department problem or problems. A lot of people talk about this post-pandemic world, and I really do not like that phrase because this has really been going on and has been studied since the 90s. We've had problems in our emergency department as it relates to number of patients getting more complex, longer length of stay in our hospitals, our staffing challenges, the evolution of the electronic health record and how we interact with it and how systems either talk or don't talk to each other. So this is really, I think, most of you that are involved, if you're involved with healthcare or healthcare administration, you've seen this in trends prior to the pandemic. The pandemic just really made it exponentially worse. I do have some nurses that I work with that they almost wish the pandemic was back because there was no traffic. And in the ER anyways, we actually had less patients because people were staying at home. But now we know that our operations teams, we need to adapt to all these restrictions of having less space, having more patients, less or different experience of staff. So I guess my question always is, how do we leverage tools, data, analytics, technology to kind of combat some of these issues? Because some of these things were not really going to be changed easily. So let's show some data about why this is a problem for me in my areas. And this is consistent with many emergency departments across the US and my colleagues I've talked to. But just so you know, for me, 47% of our fleet of nurses have less than 3 years of experience, which we see that number getting less and less. Nurses have a lot of opportunity to practice in a lot of environments, and the emergency department is not easy to work in. So how do we get people up and running to be a competent nurse, especially as we talk about triage? I do think we have a problem. So, and you know, triage is really not an easy place to work. But for those that don't understand what triage is in an emergency department, it's really a nursing process, but it is an assignment that a nurse takes in an emergency department when patients arrive or present themselves to the ED. I have this line here because we have a kind of like a line like this every day at our emergency departments. But let's talk about definitions and how we handle, or what does triage really mean? I mean, by definition, it's to sort, right? We're going to sort patients out based on acuity. We're trying to decide who's sick, who's not, who can wait. For many of us, it's who's going to take our last bed, our last treatment space. And the role of the triage nurse should really be performed by a nurse with training and competency in that specific role. So in my place, it's some of our most experienced nurses. So really, we're talking to people that are greater than 3 years experience. In my previous slide, I just showed you how almost 50% of our nurses have less than 3 years experience. So that really reduces the number of staff that we can have working out in our triage areas. And we know this is so important because this is our front of our emergency department. There's lots of evidence out there that the nurse can set the trajectory from that first interaction with how that patient's care proceeds. And we're expecting that nurse to do a lot in this short period of time. So what do we see out there? It's really not fun to be the triage nurse. You know, sometimes you have sicker patients that are out in your waiting room. You have more patients than you'd like to have. You don't necessarily have a ton of resources. This is a waiting room. So we're trying to figure out how we do more with less in a space that was designed for patients waiting to be seen. We know that patients wait longer to see a provider, and the goal is really to get those patients in front of a clinician as soon as possible. And from a quality metric, we're really seeing increased rates of left before being seen. Our AMAs and our elopes are almost left before treatment complete numbers. And these are patients who leave for a variety of reasons, but they're not getting the care that they need. So those are inherent risks of just being at triage. So as the nurse, you really have a very short window of time and opportunity to go ahead and figure out what's going on with that patient. And we already talked about how complex people are, and the medical record is complex. So there's a lot of challenges working out there. So there's some nurses that love working at triage, and there's some nurses that just can't stand it because it is just emotionally and physically draining to work out there for 8 or 12 hours. So just to give you an idea about our emergency departments here, I'm located in Connecticut on the East Coast of the United States. We have one hospital within Yale New Haven Hospital. It's one hospital with 3 campus emergency departments. We also have a pediatric emergency department that's not listed here, but under my span of responsibility, I work in these 3. So we have our York Street campus, which spans an urban level 1 academic tertiary care center. We see about last year 93,000 visits with 64 beds. Our St. Raphael's campus is an urban community emergency department. We're a geriatric specialty center, ortho spine center, and we see about 62,000 visits there, and they're 48 beds. And then we have a freestanding suburban emergency department up 95 a bit in Guilford, Connecticut, and they see about 27,000 visits annually with 16 beds. So just from a staffing standpoint, we have about 200 ED nurses, 70 unlicensed ED techs, 50 or so APPs, and about 60 EM faculty or attendings, plus we have a full-fledged emergency medicine residency. So pretty busy place, but we kind of have, I like to say we have a little bit of everything in our emergency department. We have urban academic, we have urban community, and then we have suburban freestanding. All right, so let's talk a little bit about emergency severity index. So currently at most emergency departments in the country, and actually all over the world, use the emergency severity index. So we have a simplified version of the tool right here on the slide that kind of tells you on a 5-level scale, you know, how sick a patient could be or how acute a patient could be on that scale based on information that is given or assessed by the triage nurse upon the patient's presentation to the emergency department. And this tool's been around, it's been actually almost close to 30 years. It's been around in most emergency departments. And the unfortunate part is this tool ends up being highly subjective, and nurses have a real hard time with this. We joke, there's actually, if you give this to a non-clinician and you put patients in front of them, they actually do better than a nurse many times because they're sticking to exactly what the tool says. Nurses think about all sorts of other things that are happening going on in front of them when they're trying to decide about putting an acuity for this one patient. So we know based on evidence that the validation against, you know, the likelihood of life-threatening illness and with mistriage are kind of high. So that there's it's really hard to validate ESI, or emergency severity index, against outcomes for patients, because it wasn't really designed for that. This tool was meant to sort patients. I talked about triage. We're sorting patients and trying to find out who's sick or not. But on the flip side, we know that when we apply this tool in our current environment and the complex healthcare nature, we really need more out of our triage tools than what's currently available with the ESI. So we know, like I said before, is triage, that triage level or number kind of labels that patient and can set them on a certain trajectory, because each emergency department in anywhere you ever go has different resources in different locations. And they try to tailor those resources and spaces based on the complexity or the acuity of the patient. So we know that this tool was never really designed to do the stuff that we probably need it now in 2023. So, and there's also a lot of evidence out there, and I'm just going to review some articles that talks about when they look retrospectively of how we're doing with ESI as we individual nurses perform against it. So we do have some problems. So here's a study that was done that came out of Kaiser Permanente just in March, and they looked at 5 million ED encounters in their system. They're a very large healthcare system, and they were looking at mistriage and the sensitivity of ESI to really identify patients that were having life-threatening or high acute illness. And what they found was it really didn't do that great of a job, right? We saw that mistriage happened over 30% of the time if you just took the tool and you compared it to what the nurse knew at the time. And that the sensitivity to identify patients with high acute illness was 65%. And furthermore, they tried to look and spin some bias on this and look at some of our vulnerable patient populations, as well as those that are uninsured, underinsured, and looking at race, ethnicity, and they found some disparities there. And I could tell you that at triage, the nurse doesn't see that information, right? They're looking at one patient at a time. So I think when we look at this retrospectively, we have to think about, instead of it being a people problem, it always makes me wonder, do we have the right tools? Do we have the right resources for that nurse or the person that's at the triage desk? Here's another article that came out of Yale University. So some colleagues of mine worked on this article, and they did a retrospective study looking at queue jumping. And what this means is that a patient might have been given a certain acuity level, say a 3, and they were seen before a patient was made a 2. Why did that happen? We don't really necessarily know why. There could be a lot of different reasons, but we know that I go back to, instead of it being a people problem, this is really a systems issues. We're applying a tool and we're trying to get patients seen in different nooks and crannies in our emergency departments. And it actually causes some problems with the way that we distribute the patient currently with our ESI tools. So some of the discussion points here was that some of this contributes to disparities in marginalized patient populations. So again, those that are uninsured, underinsured, as well as some minorities. In our emergency departments, we do see about 60% of our patients are in the Medicare or Medicaid system. And really some opportunities here is we should really look to standardize some of the processes in triage and to look at conscious and unconscious bias that might be associated with access to emergency care. And then lastly, there's another article about cognitive bias, really looking at that with ESI specifically. And this was an article where they took 200 or so nurses and they gave them case studies and had them complete an ESI triage on them, and that they found that there was cognitive biases with patients when they were utilizing ESI. So again, I put my high reliability hat on, and I really try to think about, how do we make I don't really believe it's a people problem. People are trying to do the best they can with what they're given. I really think that we need to do better about the kind of tools that we have. So I'll talk a little bit about my experience with ESI and my tenure at Yale New Haven Hospital and as an emergency nurse. I do see variable application. What we've seen is a lot of it has to do with who's on today. A nurse might say, oh, well, that doctor is going to question what level I made the patient, so I'm going to make them this, or I'm going to make them this to go to a certain area, because only certain acuity levels can go to this designated area. So they actually are triaging the department. They're not triaging the patient in front of them, which has nothing to do with the ESI tool, it's the application. And then also doing things that would actually you're looking at application for future care based on that number. So ESI was really validated for that first couple minutes in time when you see that patient and you're trying to say, okay, I think this is what's going to happen with them. So what they use it for is, and we're guilty of it here, is we would base our reassessment frequency of vital signs, where care areas they went to, nurse-patient ratios, based on their ESI acuity. So those that are advocates for ESI would say, well, that's just inappropriate utilization of ESI. I, again, say, I think there's tools and technology that we could implement that actually could do better to help us apply some of future care related to what the triage nurse sees up front. And then we also have this conundrum of what the provider thinks the score should be and what the nurse thinks the score should be. So nurses are trained in triage. We have a very robust triage training program here, and it is a specialty. So you are a nurse, you've been a nurse for a number of years, you've gone through different roles and experiences, and then you get trained to triage. So these nurses have been trained in what to do with ESI. The challenge is our providers think that they have an idea in their mind of what the patient's triage score should be, but they don't match. So what we need to do is some would say, well, I don't really care what this one thinks or that one thinks. I say it really matters because we're talking about patient care, and ultimately this becomes a safety issue. So we need to figure out how we see common ground and have a shared mental model, how we think about what a triage score means and how we apply it. So some trends for me anyways, before we even thought about TriageGO, is I was looking at our 5-level system data. And so it's an acuity 1 through 5. Again, 1 is a very acute patient who needs immediate life-saving intervention. This would be a patient who, if we did nothing, they could die. And a 5 is a patient who could be seen in a urgent care or a quick turnaround patient that requires very little resources. And what we found is most nurses don't like the 1 and they don't like the 5. They basically use a 3-level system. So below you can see here, we have this higher acuity skewed towards 2s and 3s, but we really don't use that many 4s. We don't use that many 5s and almost no 1s. So we end up with this big bucket of patients in the middle, which is kind of another risk all on its own, because we have these undifferentiated patients that are sitting in this acuity 3 bucket. And these are the patients that wait the longest. These are patients who have complex problems that you can't really figure out. Abdominal pain. If there's a lot of stuff that's going on in there, when we're trying to investigate and come up with a diagnosis when a patient has a chief complaint of abdominal pain, there's a lot that could go wrong there. That patient is in that level 3 bucket, and they're really undifferentiated with a bunch of other patients. So what the nurses do is they almost secondarily triage, and they say, oh, this 3 is a little sicker, but they're not a 2, so they're a high 3, or this one's a 2 because there's some protocol that says we have to make them a 2. So because they're a 2, but they're not really sick, so I'm going to make them like a low 2. So I'm going to take this high 3 before the low 2. None of this is validated in any evidence. So it's really not, they're trying to make decisions and do some of this just to survive and get the patient seen. But again, we're not really using any evidence. So this goes back to, I don't think there's anything really, this is not all terrible. I look at it as an opportunity. And this is another article that just came out from one of our colleagues from emergency medicine that talked about the application of clinical decision support tools. And that really, if you do them right, and I think this audience, you guys are probably all very invested in clinical decision support tools in your organizations. But we know that sometimes clinical decision support tools, if applied by those that aren't closest to the work and aren't really invested in trying to understand the implications, that they can actually hurt workflow or hurt patient outcomes. But we know that for us anyways, if we use different types of platform, in this article, they talked about using care pathways. They talked about using the right type of alerts to alert patients, that we can actually better care for patients. So we don't want it to be just noise. We want it to actually work and not disrupt the workflows. So I really think we have an opportunity. So I'm going to turn that kind of negative connotation about what's going on at triage and say, let's have an opportunity to fix it. So that kind of moves us into what is TriageGO. So TriageGO is artificial intelligence machine learning. So it takes patient data from patients that present in the emergency department, your emergency department. So even I told you we have 3 emergency departments and we went live with them at different times. The tool was actually curtailed to the types of patients that present to that emergency department. And what it does is it's comparing other visits within our system, and they're looking to see what were the outcomes of those patients. And ultimately, it's going to recommend an acuity. And I say recommend, and this is really important. It is not a decision-making tool. It is a decision support tool. So this is supporting the decision that you as the triage nurse would already make. And I think the important part of this is really in the education and rollout of a tool like this to your clinical staff. I could take nurses that have no experience and put them in front of this, and sure, they can come up with a triage acuity score. But blindly following any tool, I just told you in the previous slide, is it has to be the right tool, and people have to have the right education. They have to be invested in it. So we want the nurse to look at the patient, figure out what they think the patient's, what's going on with the patient, come up with a score, and use this to support the decision that you would already make. We want them to catch things because it's a very busy emergency department. You have a lot going on. You want to be able to show or be able to articulate to the nurse that you might be missing something. You might be missing a vital sign abnormality. You might be missing something that's in their medical history. So this harnesses that information in the medical record to help look at what the current patient, if they're in your system, may or have already presenting to you, and then comparing it to other patients with similar chief complaints and their outcomes. So here's some data that came out of Hopkins from their prospective study when they went live with this tool. And what they found was that big group of patients in the middle, those mid-acuity threes, and I call them undifferentiated threes because there's a joke I say when it comes to triage training. Well, when in doubt, just make them a 3. And that I've heard that by triage nurses. So we have this big group of threes. And what they saw is they saw a reduction in the number of, or the percentage of patients that were acuity 3s, and this was sustained. So we know that they took that basically took those 3s and it differentiated them. Some were sicker and some were less sick. And then it also saw the increase of lower acuity patients. So the big change here, and I'll go back to just this slide for a second, is that when we look at what information, the shift from ESI to, which is a static tool, to a machine learning tool, is we're going from a resource-based tool. So when with ESI, we have a decision point that the nurse has to make. If the patient requires a number of resources, EKG, labs, diagnostic imaging studies, that they can't be a quick turnaround patient. They need to be a level 3 because they need resources. I talked earlier about patients are complex. Physicians and clinicians are going to order resources on a lot of patients. That does not mean that they're all sick and need hospital admission or need to go to the operating room or go to the ICU. So we need to think differently. And that's what this tool does, is it shifts us from that mindset of resources to risk. What is the outcome of the patient? Are they going to get admitted? Are they going to have mortality on this visit? Are they going to the operating room or are they going home? And it's helping us differentiate those patients. So again, with this, they saw a number of lower acuity patients jump up. So some of those 3s were dropped down into the level 4 bucket. Some of them went up to the level 2 bucket. So, and you can see that here in this slide, where when we talk about the redistribution of those patients, the gray bars was with ESI, and then you can see the drop with the TriageGO, and then the colors show where those patients ended up. So the bulk of those 3 stayed where they were. The nurses weren't doing a bad job. Those patients were a little bit higher risk of being admitted to the hospital, so they're appropriately put in the level 3 bucket. But many of those patients could be dropped to a level 4 or 5, meaning that they're going to most likely get discharged from the hospital. And some of them are going to move to acuity 2, where they are actually sicker, more acute patients that need more timely intervention. So that's just, that shows that visualization there. And then here's some stuff, just some additional data about kind of the ability of the algorithm, ability to kind of assess and predict the patient outcome. And you could see some of that data there. And what they saw was, for Hopkins, is that they saw an increased rate of the critical care patients that went to ICUs, went to the operating room. Those were moved from 55 to 78% of those patients were moved into that, were recommended a 1 to 2. And that we saw for, again, same thing with, sorry, that was more for critical care. The next bucket was for emergent procedures that were identified as higher acuity, were 1s and 2s. That was an exponential improvement from 30 to 62%. And then we saw a rate of the low acuity hospitalization. That rate went down from 6% to 3%, because at front, nurses are very afraid of making patients low acuity, because when you make them a low acuity, they're afraid they're not going to get the appropriate workup, or they're not going to get the time that they deserve when they're talking about being seen by a clinician. So this was really a culture shift of changing the idea around a 4 or 5 doesn't mean you're not sick. It doesn't mean that you don't deserve care. It means that you're not going to die today. You're not going to get admitted to the hospital today. So I think it is a shift that we've seen. And then this is just another visualization about identifying the outcome compared to ESI. And we could see, again, those 3s were being shifted to 2s. So those patients that were in that big undifferentiated group of 3s that needed a lot of resources, the nurse was missing those. They were missing subtle differences in patient acuity because of just the noise. So this was able to help identify those correct patients, getting those patients up triage to a 2, and risk stratifying patients who were appropriately could get out of the 3 bucket and move to a 2. And also Hopkins noted some time saving when it came to getting patients seen by a provider. They saw the right patients quicker. They got patients doored at disposition for admission quicker, and they saw a reduction in their time to discharge for their fast track patients. All right, so some people want, so what I always want to know, so I'm a nurse, right? So this is impacting nursing. And one of the things that we wanted to make sure is to talk about how this actually works. What does the end user see? There's a lot of math that happens and analytical things that are happening when this tool was built, and a lot of planning went in place for us to build this. But what is the interaction is me as the triage nurse. So there's information that is already obtained at triage. So demographics, I have to know their name. I have to find out how old they are, what their sex was assigned at birth. We have to know how they presented. Did they come by ambulance? Did they come by car? Did they take a helicopter or a horse? Their chief complaint and vital signs, complete set of vital signs, as well as we'll pull in past medical history and medications from their visit. Excuse me. And that is how the nurse gets information into our electronic health record, which is Epic, in full disclosure. So a shift from ESI to TriageGO, again, I mentioned this earlier, it's not based on resources. We are shifting to a risk-based model. So again, I put that algorithm down at the bottom where it talks about how many resources the patient would have. And they're basically, if you need many resources, you're going to need to be in acuity 3. So we're looking at critical care needs, emergent procedures, hospitalization, and fast turnaround. And that's the major difference. So we're kind of trying to deprogram nurses to think about resources and really look at the patient. When you see a patient in front of you, do you think that patient's going to be hospitalized today? And you're looking at their vital signs and you're looking at the recommendation. You can agree or disagree with it. So let me show you what that looks like. So this is our nursing triage screens. When a nurse is inputting their data, they go down. For those of you that have Epic, I'm sorry. Well, some of it might be boring to you, but when you get down through your triage screening, when you arrive a patient, there's this full or rapid triage activity. And what happens here is you've inserted all that other information I've said before, your vital signs, your the patient's information, their chief complaint. And what happens is you're given, this is a box that already exists. So the bottom half of the screen already exists from where it says rapid triage. The nurse would normally pick a 1 through 5 and hit OK or close. Here, what it does, while it's added, is these 3 boxes. And what it'll do is it'll automatically populate what the score recommendation is. And it tells you, so it's giving you some support. This is telling you it's a clinical decision support tool, that the nurse, the recommendation was a T3. You can look down here and say that's urgent and it's moderate risk of hospital admission or low probability of intensive care, emergent procedure, and mortality, right? And then the part I really love is the part it says, it tells you the why, because I'm a why person. I want to know why it's saying or doing a certain thing. And it says right here, moderate risk of hospital admission driven by their age, their extent of their medical history, and normal vital signs. So now you have a decision to make. As a nurse, I can agree or disagree with this, and I just pick the score that I want. So in this case, the nurse actually did not agree with it. You could see they picked a 4. But the other part that I like about it is they can say, I didn't agree with it, and they could say why they didn't agree with it. And then there's transparency. So on the provider end, this shows up in the, this is a different case just for transparency, but I like this one because The nurse, this is a triage summary report in Epic. So when our providers are looking at a patient for the first time, they click on the patient, they see this information, and now it's transparent to them. So they could see the why behind it. They see some of the data, but here in this case, the patient was recommended a T3, and it said moderate risk of hospital admission driven by ambulance arrival, chief complaint, normal vital signs. TriageGO agreement, no. And the nurse put why. They said, I don't agree with it. They have a 10 out of 10 headache and they have an AV shunt. That is a high risk situation. The patient was made appropriately a triage acuity level 2. So the tool, again, it works better in conjunction with the nurse. It's not an autopilot tool. This is to support decisions at triage. So now I hope I illustrated to you the differences with when a patient is presenting to a busy emergency department, how a provider can now see and have that shared mental model of the triage nurse. We didn't have that transparency before. The nurses and doctors didn't talk about the levels. They were just numbers on the board. So now this allows the provider to understand the decision-making of the nurse at triage. All right, we'll talk a little bit about our timeline here. So 2021, excuse me, we went live with our freestanding ED first. We made a decision to do that based on, we have some of our most experienced nurses. I talked about experienced nurses. They work at our freestanding ER because they have the most experience and they have the least number of resources. They don't have respiratory, they don't have inpatient beds. They kind of really have to be jack of all trades. They got to figure it out. So I figured if we could start here and make it successful, I'm sure these nurses have been using ESI the longest. So if it's not going to work, it's not going to work here. So let's try it there first. We did that in 2021. And as you can imagine, it was pandemic time. So everything was kind of crazy. So we did take a pause on additional rollouts, but we did roll out the York Street campus. That's the academic level 1 in January of this year. And then we waited a couple months, made sure it worked at the academic center. And then we rolled it out to our St. Raphael's campus in April of this year. So now I'm just going to show a couple charts. So we talked about this distribution. I apologize, the colors in the charts. Some people like them, some people don't. So this is York Street. So this is our academic center. We went live on January 20th. So I took data from December back, excuse me again. And what you could see is what I was talking about before around the way that the acuity distribution was. We have a lot of 3s and a lot of 2s, not so many 4s and virtually no 5s. People were afraid to make patients 5s. And when we launched TriageGO, you could see we've had this steady decline. So from actually before December, we were like close to 60% at York Street alone for acuity 3s. And we've seen that drop as of August, it was 34%. So I think those patients got distributed. You could see the distribution shift from back in December, where we've even shifted some of those 2s to 3s, as well as some 3s to 4s. And the other thing that's really interesting is our acuity 5s. So before this, nobody would make anybody a 5. This empowered the nurses to feel comfortable putting that acuity 5 on patients. So now we see at York Street, which they are the transfer center. So I'm not surprised that they have less than 10% acuity 5s, but they do have about 6% up from virtually nothing. Similar trends, a little bit different at the St. Raphael's campus. We were about 51% prior to go live in April, and now we've seen that reduced to about 40%. Many of those patients did shift down to 4s and 5s. You could see here, we were able to make operational changes to say there were certain patients that we wanted to go to a certain area of the department based on the fact that they were not going to be admitted to the hospital. So we actually saw a ridiculous increase in acuity 5s, which meant that we were able to staff an area for lower acuity patients to increase their turnaround and get them seen quicker. So again, the nice part about this tool is we talk about standardization and having a standard tool, and that was talking about the way that we think about the patient from a risk perspective. But we then apply the tool differently based on the patient population that presents to your emergency department. So when we were going through the analysis for the emergency departments at Yale New Haven, the tool looked a little differently because the outcomes of those patients are different than the ones that present at the other sites. So the tool does look the actual way that the tool predicts is slightly different, and it will, like any machine learning tool, it will adapt over time. All right, so let's talk about some outcomes. So this is from January to September. what are we? I pulled this like a week ago. So first couple weeks of September. And what we've seen is for critical care outcomes and this is based on nurse assigned. So this isn't recommendation. This is what the nurse actually picked. And I already told you that this tool works better when it is the nurse is using it as a support tool to make a decision. So here we have our critical care, the ability to identify critical care. So these patients went to an ICU, had an emergent procedure like cardiac catheterization, emergency surgery. And you could see our low acuity patients, they're not going to ICUs. That's good, right? So no low acuity patients are dying. That's awesome. And some mid acuity patients are going to critical care, but the bulk of them are 1s and 2s. So that's good. That's what we want to see. We see for hospitalization, very low percentage of patients are getting admitted to the hospital that are lower acuity patients. I would not expect this to be 0, but I'm glad that it's pretty low. And you could see a big chunk of our 1s and 2s are high acuity that get admitted to the hospital, and some mid acuity patients, most of those are getting admitted. And just to mention a little bit about high acuity, there are patients who present to emergency departments that we do a great job. We stabilize them. They come in, they look really sick. We stabilize them, and then they go home. It happens. But we almost over triage those patients. So it's not unusual to see some of those higher acuity patients not get admitted to the hospital. So I feel like we're catching our critical care patients. We don't have a ton of patients being hospitalized in our low acuity, and we're sitting at around 70% agreement rate with the tool. So there's about 14% up triage and about 15% down triage for our sites with the tool. And I'm actually okay with that, because to me, it's not about the percentage of patients that are the staff anyways agreement. I get concerned with staff that would blindly agree with the tool 100% and those that don't agree with the tool. So when I look at data, I actually look at the outliers, the people on either end of that curve. So if you're in the low or the super high, you're a dangerous triage nurse, and we need to have a conversation. So that's very different. If everybody's in alignment, I'm okay with the 70% so far from what I've seen. All right, so now I'm more of an administrative role. I am an ER nurse, but I am more administrative role. So why I like this kind of stuff. So it's nursing focused clinical decision support, right? It's supporting the decision. I said this a bunch of times, so I apologize. Supports the decision the nurse would already make. The tool's not making it for me. I'm going, yeah, that makes sense, or no, it doesn't make sense. And we know that that's best for patient outcomes. I really like that. We're reducing variability, and we're seeing relatively what we thought we'd see. We saw good outcomes when we implemented the tool. And I'm actually really interested in bias. I'm really interested to see how this all shakes out with bias. And we're really hoping to study this a little more, because I've already presented some articles about how our current triage systems across the country and the world really aren't set up. They're not helping us with bias. So we really should think about that. I don't think any nurses set out to treat one class of people or one ethnicity a certain way. I think it depends on your patient population, and we need to have better tools. This doesn't change usual triage workflows. It's simple, right? So from a nursing perspective, I don't have to go to another screen. There are other tools out there that are actually on top of your electronic health record. So you have to have that open and your electronic health record. From a user interface, it's very simple. We have data to share. We haven't done a lot with sharing individual feedback with nurses. I'm being careful with that, because I'm always cautious when sharing data out of context with a nurse, that we could have a negative impact on their ability to perform when they're making decisions to triage. So, but we do have that data, and we can track and trend it. Where before, I mean, we would have to do this manual. We have to do manual auditing and really understand, well, why did you, case by case, the feedback to nurses was very much individual basis. You would say, oh, you had this bad event at triage. You left a patient out in the waiting room. They had a seizure and had a bad event. You're a bad triage nurse. Like, that's not helpful. They're not seeing you triaged 1,000 patients this year, or you did whatever, and being able to look at it at an aggregate level. So I think this is going to be helpful. I know I mentioned it again before, that shared model of thinking between a provider and a nurse is crucial. We're a team. Emergency department, nursing, and providers work very closely together. Nurses have they have a role in the department that may be different than the physicians or the clinicians, but we rely on each other to work well together, because it's almost impossible to survive otherwise. I like that the fact that this is based on evidence based on your patient population, because my patient population here in Connecticut is going to be different than where you are. And you may see different types of patients based on the type of hospital or emergency department you are. So I like the fact that it is based on the patients that come into your areas. And that there is some customizable things that are based on unique operational needs of our department. So I talked about the acuity 5s going to certain areas of the department. Now, with ESI, we just arbitrarily said 5s can go to this area, but we didn't get any 5s because nurses were not comfortable making patients 5s because it wasn't validated. This tool is saying a 5 is going to be a quick turnaround patient. And we looked at that data and we implemented it. We saw the ability to leverage resources to see patients quickly in those areas. The other thing I said it before about the, excuse me, the messaging, that supplemental information that you get, that's like my favorite part of the tool, is that we have certain special populations that regardless of their risk, there's certain elements that need to happen for their care. And I'll say something like operational exposures. If you get a needle stick, so we have a provider that gets stuck by a needle, that patient's not going to get admitted. The risk of them going into the hospital is very low. But there's interventions from an emergency department perspective at 3 o'clock in the morning. We need to get them in front of a provider, assessed, and get them on prophylaxis treatment immediately. So those patients, we have supplemental messages to support that triage nurse to remind them that, hey, this patient's a needle stick, do this, this, and this. Sexual assault patients who come in with victims of sexual assault, 99% of them go home, but they need a private room. They need to be assessed rapidly, and we need to get specialty resources for them. So that's another one we implemented. And lastly, we're doing this work with pregnant patients who come in who are either pregnant or postpartum and have headaches or signs and symptoms of eclampsia, trying to cue the nurse of those warning signs. We're using the messaging there to help with that. All right. So we're getting there. We're wrapping up here. So the nurse's perspective. So I'm a manager, right? And I love project work. I love data. I'm the data geek. Everybody says it. So what do the nurses think? I had nurses that were very reluctant to use this tool. They were like, oh, I'm not going to like this. I've been triaging for 20 years. I know best. And I said, just try it. Some of the nurses that actually love it the most since we went live are the nurses that are veterans, because they said, you know what, this makes sense. This is what I wanted to do before anyways, but I was making decisions based on who was on or all those other things I was telling you about. So I do want to use this quick story because I love using patient stories, because I think so sometimes anecdotes aren't helpful. I think this helps paint a picture. So here's our freestanding emergency department off 95. It's 5 o'clock in the morning on a Saturday. We have a 19-year-old male who presents to the emergency department with a sore throat. So this triage nurse, she's been a nurse for 20 years. She is on night 5 of 6. And oh yeah, she's on a 16. So she's working a double today. And it's 5 a.m. She's like checking out, right? She's tired. She's going through talking to this patient a little bit. I don't think she was like this on the stretcher, but she was probably feeling that way in her brain. She sees the TriageGO score and it says acuity 2, and it says high risk of critical care. I'm not going to spoil it for you. And she did one of these. And then she looked at the vital signs, and it said because of severe tachycardia and patient's febrile. So patient's got a temp of 102.8. She did not do the vital signs. The tech had done the vital signs, put them in the computer. She got called out to triage to do the triage. So she's like, wait a minute. So she looks at him and then she puts it together. Oh, he's drooling. He's got stridor. He's got a high fever. He's looking at his lips. He's got epiglottitis. Now, so those of you that aren't emergency people or clinicians, this is an emergency. This is like an oh my gosh emergency. So he got rapidly transferred to our main campus emergency department and was seen by ENT and actually had a good outcome. So I bring this case up as not, this was a 5 a.m. case, but she brought this to me and said, I didn't think this was a great tool, but then I saw how easily it is for me to be distracted from a number of things. I'm not saying that she should be working a double and that this should save her, but I think this is just one case scenario. I could give you 20 other case scenarios where there's 30 people on a line and you're trying to just triage the line, and there's things that you will just inherently miss. It's something as simple as vital signs, because you're not really thinking about it. You're thinking about 19-year-old with sore throat. You're fine. So let's just do some closing thoughts as we wrap up here. So I think my thoughts are here. We need to use the power of the medical record for good, not evil. Many of my colleagues and providers, we keep saying, no, 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 to clinical decision support tools because they are nuisances. So we need to use it for good. So let's think about the appropriateness of using clinical decision support tool in AI. So I love the fact that this is a tool that supports the assessment of the nurse at triage. This is supporting what the nurse is seeing out there. It's aligning that nurse and doctor on what that score means and how we proceed. And this gives you actionable data and the ability to sustain a process change through reporting and data. So we can make it better. So if something's not working, we can talk about it and we can figure out how to identify outliers and make it better. So with that, we'll go through the Q&A. Thank you guys so much for your attention. And I think Cabrina is going to go in and go through some of the Q&A.
Hey, Chris. Thanks so much. That was great. Really appreciate it. Cabrina, are you going to start with some of the questions?
Yeah, we have quite a few questions. I'm so happy to see this. So we'll try to get to all of them. But thank you again, Chris. That was a wonderful webinar and very informative. So we'll start with, from most recent to last, Kelly Wright asks, I'm curious to know how the triage level shift impacted resources. Has that been analyzed? If so, have there been certain resources that were more efficiently utilized or others that were more stressed?
Yeah, so I think for resources for us, when I talk about resources with triage level determining acuity, it was, do they need X-ray, CT, MRI, those kinds of things. So I think for us, I haven't really spent a ton of time looking at the patients that had what resources they got in a 4 or 5 bucket compared to what the but I can tell you that a number of patients, I'll use abdominal pain. Many abdominal pain patients who came into the emergency department, it was like, you're a 3, you're a 3, you're a 3. It didn't matter. I always use KFC eating chicken abdominal pain because that person has they're eating KFC chicken. They have normal vital signs. They're young, they're healthy, have no medical problems, and they're having some upset stomach. That's very different than, appendectomy or appendicitis abdominal pain. So we've noticed that we should treat those patients differently. They would all get lumped into a 3. So those patients still might get a CT or an ultrasound or labs, but they're going to go home. So they're going to be a 4 or 5.
We have another question. Have you measured, this is from Danielle Burness, have you measured any other patient outcomes for Yale New Haven Health System? For sure, would love to see the data on bias, but what about data like length of stay or patient experience? That's
a great question. And I know Danielle. So we have been looking at some of the outcomes for bias. It's something that like I said before, I'm very interested in, and we're trying to figure out a way to capture that. Again, being an ER nurse, jack of all trades, I would say that the whole studying of bias is very not new to me, but getting in how we measure it is new to me. So that is something that we're really looking at our system and trying to figure out how we look at our current triage tools with that.
Yeah, it's actually something that Beckman Coulter is looking into as well, because we want to make sure that we are part of that conversation and have that data ourselves. Daniel Colby asks, were you able to reduce triage times?
So we did reduce some triage times. Triage times are kind of a loaded metric because depending on your operations up front, if you have the patient arrive by the nurse or by some other role, but we have seen some reductions. I haven't spent a ton of time measuring it, but anecdotally, we've seen reductions in triage time.
Okay. And we have another question, anonymous. How many data points patients triaged have you gathered using TriageGO thus far? Chris, do you know at Yale how many you've had?
I don't know off the top of my head. I should know that number and I don't. I apologize. I remember when we were doing the analysis we looked at I think there was at least 300,000 visits that we looked at before. So we're in September. I think we're probably with TriageGO about 60,000 visits at the York Street campus that have used the TriageGO.
Okay. I have another question from Daniel Colby. How is TriageGO balancing the bias of AI to prioritize patients with more documented PMHX and the inequities that causes?
Yeah, no, it's a great question. So I think it's a balance, but we do have, I think we're fortunate. Most of our patients that present to us are in Epic. So we have used certain medications and certain elements of past medical history included those. So I don't think it's not this wide net of all medical history and all medications. There was some decisions about what was included and what was not.
Our next question, actually, I'll be able to address this. This says, if the data was analyzed based on the extent of the medical history, what happens when they have no history available in the EHR? So the algorithm actually has a built-in mechanism for this. It understands, because this is a common occurrence, especially in areas where you might have a big tourist population. So it would understand and interpret a 21-year-old with no medical history differently than it would understand and interpret a 56-year-old with no medical history. So it takes into account that a 21-year-old might not have any medical history, but a 56-year-old probably does, and it will weigh that into the algorithm appropriately. Anything to add, Chris? I don't know.
No, that was good. Sorry, I'm sucking on a cough drop.
No, that's fine. Keith Baldwin asks, in order to build the initial model, you need a lot of data to train the system. Did you already have the data initially, or did you have to start collecting before you build the model? So actually, this is another one that I can give some color to. When we implement the model, we do a 2-year look back, or we take about 100,000 patient records, whichever comes first. And that's how the model will train. So we do a data file transfer, we train the model, we localize it to your site, to your patient population and your historical outcomes. And that's how we train it. It's not that it's trained and then we just implement the same model at every site. That's actually a very important part of the model. It's localized to each individual site and each individual patient population, which is part of what makes it so effective. Chris, any other detail?
That's good.
Okay. From Taryn Brown, is there an opportunity to pull from larger data sources, for example, multiple hospitals and various health systems, to make a more powerful model versus only internal EDs? And that's from Lindsay Stringer. So, oh, that was from, sorry, I'm reading them 2 lines apart. This isn't something, again, back to the localization question. I don't know if we would ever combine data from different sites to train the model and then implement across sites. I think we would always want to train the model on the data that is from that site, because that is part of what makes it effective. But it could be a question for our data scientists, so I could forward that along.
Yeah, and I think that just the only thing I would add to us, because we did it at the 3 sites, that we looked at them individually, but we did look at them together. So I think that was the nice part of being able to look at the data all together and say, what would the tool be different at each site? So we were actually able to plan and look at that.
A question from Arnold Lee about, was it called Stochastic? Yes. So the startup that was affiliated with Johns Hopkins and Towson, that was where we invented the tool, that startup was called Stochastic. And back then the tool was called HopScore or eTriage. So if you look, there was an article published in the Annals of Emergency Medicine. And in that article, it's called, it's by Dr. Scott Levin, and it's called eTriage and HopScore kind of interchangeably. So a lot of our peer-reviewed evidence still has the old brand name, but yes, it's the same tool. And from Alan Young, are Schmidt-Thompson triage protocols still being used by triage nurses in ED and clinic? Chris, you could take that one, probably.
I am not familiar with that. It's a good question. I have not used that, but I don't know. I have not used that. I'm not familiar with the Schmidt-Thompson triage protocols. Some homework for me.
And from Paul Burens, he asks, he just says these trends are international and they're more acute here in the US and do not seem to be changing yet. So I would agree, Chris. I don't know if you guys have seen, like, system-wide, if you've just seen this kind of crowding as being insidious. And yeah,
it's everywhere.
Mm-hmm.
I've added a few more questions on the bottom of the there, Sabrina. We've probably had another 10 or 12 questions since you've been speaking.
I'm trying to scroll through too.
We can't keep up.
I know, I can't. Freddie, where did we leave
I know that
off?
there's something about EHR other than Epic. You guys use Epic and Cerner, right?
Yep, so we're in the Epic app market and we're in the Cerner code program as well. I'm actually here at the Oracle Cloud Conference this week. So we got to talk to all the Cerner Oracle guys, and we are integrated as well. But that's not to say we can't integrate with Meditech or others. We have the data scientists on the team who can implement on the back end. We could just build a custom integration. for pretty much any EHR.
Another question here,
Okay.
Chris. Oh, sorry, I was just going to say, has the ENA endorsed this tool? And
Yeah, I
that's
saw that.
Griffin?
That's a great question. So the ENA, if people that don't know, they actually purchased ESI. So ESI, again, it hadn't been updated in many years. They purchased ESI, and they did just release an update to ESI through the Emergency Nurses Association. And they do not endorse this tool, but they're using another type of AI tool that uses ESI as the basis for it. So I don't want to take too much time on this, but I think it's important to note that my opinion is that ESI, even with the changes, isn't addressing some of those differences between the nurse and provider, as well as what the outcomes of the patient. They're still taking what the principles of ESI, which aren't bad. They're taking those principles and they're applying them with an AI tool. So I think it doesn't really address the issues that I'm interested in, is what ultimately happens with the patient. And there's an argument to be had. You can find all sorts of stuff about their, I think it's Mednition product that you can find out about that. And I'm happy to answer other questions with that offline, because it is very interesting. But I do think that this tool is very simple in comparison to the other, called Nurse Kate is the product.
Do you want to keep going with the questions? We've still got a whole load of them here.
Yeah, sure. I also saw there was something else about the timeliness of getting the actual recommendation. It happens very quickly. So once you put those data elements in, we're talking seconds. As long as those data elements are in, you get a score recommendation within a couple seconds. The only thing I would say is operationally, we did have a challenge with we have unlicensed staff that may use a vital sign machine that then has to send that data electronically through the cloud into Epic, and you need that data for it to make a score. So that was something, just a timing of when things happen at the same time, and we need to actually get that stuff done before the score is entered and a recommendation comes up. So that was probably just the only big hiccup, is that nurses and techs were doing stuff simultaneously, and you kind of have to just give it a second or two to do its work.
Another kind of similar question from Samuel Valancourt. How have you modified your workflow with this modified triage system?
Oh, that's a great question. So I know we're running up on time here, but we had, during all of this, we implemented a temporary emergency department space that was 35 curtain beds. And we said, we want to be able to get patients who we know are going to go home, because it was like a block away. We ran 30,000 visits through that emergency department space in a year. And we were able to drive some of those patients based on TriageGO to be able to say, these patients are going to be 4s and 5s. Those are the patients we want to get to that area. Because what we were doing before is we were having a provider up front that was helping almost secondarily triage those patients.
There's a ton of questions here. I could address a few really quickly. So from Alexei Levici, was the tool developed based on rules? What kind of ML? I can forward this question to our data science team, but the tool is a random forest model with clinical compartments. So it is supervised AI. It's not just random forest on its own. There are clinical compartments that go into it, and we can adjust those clinical compartments per site. So if your site has certain sepsis protocols or other cutoffs or procedures, we can build that into the model, but it is, at its core, it's a random forest model, if that helps. We are not, the next question from Eugene Poznikov, we are not tracking readmissions or post-discharge only because it's a hard thing. We're trying, it's a very hard thing to track. But we are tracking the outcome at the end of the ED. So what happened at the end of their journey in the ED? Did they get discharged? Were they admitted? Did they have an emergency procedure? Were they admitted to the ICU? Those are the outcomes that we are tracking against. And then would TriageGO work differently in the case of a different EHR? No, it's the same widget. It looks the same from a UI perspective. You almost wouldn't know that it wasn't part of Epic or that it wasn't part of Cerner. It just embeds right into the UI. It's no extra clicks, no extra pop-ups or anything. It's very seamless UI. TriageGO is cloud-based. And we are working on trying to, sorry.
No, there was a question about, where did it go? I just lost it. about shared systems for CDS working together to help with outcomes. I think there's a lot of stuff impatient for these kinds of things, but I would really like, I really think this is interesting. I like to see, so what is now taking this to the next step? Wouldn't it be great to say almost an evolving triage score, a score that evolves with the patient? We have some of that on inpatient. They look at trends of vital signs in the patient's outcomes. But I think in the ED, you know, patients change so rapidly. I would really like to see that. So I know that's some stuff that some of my colleagues are working on.
I saw that question too, and I wanted to address that. So when Beckman Coulter acquired Stochastic and we absorbed that team, we also established the new CDS department. So we have upwards of 60 people on our team now, and we're committed to innovating CDS technologies for emergency medicine. So we'll have things on the horizon.
There's a question about nursing documentation burden. I think that one of the things that we're constantly trying to deal with is how many clicks people have to make. So when we talk about clinical decision support tools that you have to click and you're stuck there, this doesn't do that. So I think that's the part that the simplicity of it is so important, because it's there. We train people to know it's there and help it make decisions, but it's not stopping you from doing anything. It's not increasing any burden or clicks on you.
Yeah, it looks like we're at time, but I think, Freddie, we can track all these questions and we can address them via email. I'd be more than happy to connect all of you with the correct, we have a whole team of nurses, MDs, and clinical informaticists who developed the technology, and I can connect you with the correct person. We can get all these questions answered.
Yeah, we'll definitely do that. We'll take all the questions and make sure we get them over to you, Cabrina. Yeah, just a huge thank you to you, Chris. Really appreciate your presentation today. You did a great job there. And thanks to Cabrina and the Beckman Coulter team for supporting this webinar today. And thanks so much for all the attendees and all their questions. We really appreciate it. Great session. This will be put up as an on-demand video. It'll be in the website a bit later today. I'll get cracking and get that straight into there so people can come back and view it. And yeah, thanks so much, everybody. Really appreciate it.
Thank you.
Great.
Thank you both so much.
Cheers, everybody.
Bye.
Bye-bye.